Good afternoon, everyone. Our next topic is the physical examination of the peripheral vascular system. This is going to be the outline of our discussion. I'm going to quickly review the anatomy and physiology of the blood vessels. Not just the blood vessels, but also the lymphatics. Then, we're going to look at the things you need to ask for in the history taking. In the physical examination, I have divided them between the upper extremities, the lower extremities, as well as the abdomen. There are also some special techniques that you need to learn. And lastly, I have some notes about health promotion. Okay, starting now with the anatomy and physiology. So, I have divided the anatomy and physiology into these three parts: arterial, venous, and lymphatics. And I also have some notes about transcapillary fluid exchange, which is the physiology part here. Okay, so this is the arterial system. These are the layers of your arteries: intima, media, and adventitia. Okay, so endothelium is the one that is in contact with your blood. So, of course, aren't you wondering why blood doesn't clot when it's inside the blood vessel? That's because the endothelium is not promoting blood coagulation. It actually has inhibitors to blood coagulation. Okay, aside from that, what's the thickest part in the arteries is the media. So it has a thick layer of smooth muscles. So what are some of the conditions affecting the arterial system? At this point, I would like to differentiate between various terms. Okay, so we have arteriosclerosis. Okay, it's the most general term. Under that, arteriosclerosis just means loss of elasticity of the blood vessels because of hardening or thickening. Under that you could have atherosclerosis as well as arteriolosclerosis. Okay, atherosclerosis means fat deposition, but not just fat deposition. There's also inflammation on top of it, so it's not really reversible. Not because you lose weight doesn't mean that your risk is already decreasing. Okay, in contrast, arteriolosclerosis means hardening or thickening or loss of elasticity of the blood vessels. Okay, but specifically it refers to the arterioles or the small arteries. Atherosclerosis happens mostly in large vessels, large arteries. For example, the coronary arteries, the carotid arteries, the cerebral arteries, right? That's why you have myocardial infarction, stroke. There. In contrast, arteriolosclerosis happens in the small arterioles. Okay? And you see this mostly in hypertension. And there are two types: hyaline and hyperplastic. Hyaline means glass-like. So it happens because proteins extravasate or they move out of the blood vessel. In contrast, hyperplastic means there is growth in or increase in number of cells. That's why it has a characteristic onion skin appearance on microscopy. Okay, so setting that aside for now, what's here in this picture? What's depicted here in this picture is an atheroma or a plaque. So usually, atherosclerotic cardiovascular disease starts as a fatty streak. Eventually, because of fat deposition as well as inflammation, for example, in the formation of macrophages that settle on it and they become foam cells, they try to digest the fat or the lipid, the deposited fat or lipid, but they cannot do it. They just transform into foam cells. Okay? So there. Atherosclerotic cardiovascular disease, one of the most important diseases that's relevant to examination of the peripheral vascular system. Now, going back to anatomy. These are the arteries of the arm. Of course, there are many more terms in anatomy, but for now, I just want to emphasize that there's a brachial artery here in the arm. By the way, this is the arm, and this is the forearm, right? So the brachial artery bifurcates in the brachial fossa into the radial, which is at the side of your thumb, and the ulnar artery. So why am I emphasizing that? Because we're going to palpate for pulses there. And also, if you're going to do phlebotomy, you could also get, but phlebotomy is for the veins, of course, but you're going to take it from this fossa. Okay? Now, let's move on now to the arteries in the abdomen. What's important to learn here is the abdominal aorta and its three major branches. Okay? The three branches have relevance in development, what we call ontogeny, okay, as well as in the anatomy of the adult. Okay, so the three branches correspond to the foregut, midgut, and hindgut. The celiac artery supplies to the derivatives of the foregut. That includes the distal esophagus, the stomach, the proximal duodenum before the ampulla of Vater or the sphincter of Oddi, the liver, the spleen, and the pancreas. Okay. In contrast, the superior mesenteric artery supplies the derivatives of the midgut. Okay, so it supplies the distal duodenum beyond the sphincter of Oddi, the jejunum, the ileum, as well as the ascending and the proximal 2/3 of the transverse colon. In contrast, the inferior mesenteric artery supplies the derivatives of the hindgut. So it supplies the descending colon as well as the cecum. Okay? Take note, this figure is erroneous. Okay? This should be descending colon as well as the distal 1/3 of the transverse colon. Okay? So, we're done with the arteries of the upper extremities and the abdomen. Let's move on now to the arteries of the leg. So, the most important one is this, the femoral artery, which later becomes the popliteal artery. Okay? It bifurcates into the posterior tibial and the dorsalis pedis artery. Okay, so we're done now with the arteries. Let's move on now to the veins. Okay, so for the veins of the leg, the largest ones that are probably visible in some of you would be the great saphenous vein. It's here. The majority of your blood drains towards this tributary. Aside from that, we have the small saphenous vein, which is located posteriorly. But overall, it's going to drain later on to the femoral vein. Okay, so we are done with the arteries and the veins. Now let's move on to the lymph nodes. So for the lymph nodes of the arm, take note, by the way, for all the lymph nodes, that you could only palpate the superficial lymph nodes. Of course, there are deep lymph nodes, but you cannot palpate for them. Okay, so for the lymph nodes of the arm, the majority of the lymphatic drainage goes to the axillary lymph nodes here. However, take note that the ulnar aspect of your forearm, as well as the little finger or the fifth digit, as well as the ring finger or the fourth digit, drain via the epitrochlear nodes first. Okay? So epitrochlear nodes, if it's in the ulnar area, which later drains to the axillary nodes, which drains most of the arm, but some, very few, drain directly to the infraclavicular nodes. Now, that's for the upper extremities. But for the lower extremities, we have two groups that we have to learn. The horizontal group and the vertical group. The horizontal group is located around the inguinal ligament. It's located higher in the leg. And take note that it drains the superficial portion of the abdomen as well as the buttocks, the external genitalia, except the testes. It also drains the anal area, okay, anorectal area. In contrast, the vertical group drains the leg. Okay, so the horizontal group, upper portion; the vertical group, the lower portion. And take note that there is a certain portion of the leg that which is drained by the small saphenous vein. So the lymphatic drainage there goes deep, so it's not palpable. Okay. And lastly, for our review of anatomy and physiology, let's talk about transcapillary fluid exchange. Okay, so what's the primary determinant of transcapillary fluid exchange? If you remember our lecture on plasma proteins, it's albumin, of course. And aside from that, transcapillary fluid exchange is caused by a balance between hydrostatic pressure and osmotic pressure. To put it simply, hydrostatic pressure is like a pushing pressure. Okay? While osmotic pressure is like a pulling pressure. To put it simply. Of course, in the blood vessels, the primary osmotic pressure is, or oncotic pressure is that which comes from albumin. Okay? So for example, if you have hypoalbuminemia, for example, if you have chronic liver disease, or if you have poor nutritional status, then you have lower oncotic pressure, lower osmotic pressure, and that's going to cause edema because fluid is not going to be pulled into your blood vessels. Okay? So now, after our review of anatomy and physiology, let's go to the things that you need to ask for in the history. Okay? So what are some of the concerning symptoms when you talk about the peripheral vascular system? So here we have a list of common or concerning symptoms. But before we start memorizing this list, I would like to first explain the rationality behind the different diseases. Okay? So peripheral vascular disease could be either a problem in the arteries or veins. Okay? Arteries bring blood away from the heart, while veins bring blood back toward the heart. So if there's a problem with your arteries, the manifestation is like a faucet that has stopped flowing. So it's going to appear pale. There's also going to be it's going to be cold to the touch. There may also be hair loss. Okay? In contrast, if the problem is venous in origin, then there is a problem with return of the blood from the peripheries back to the heart. So the appearance is more likely more of congestion. Okay? There may be varicosities. Aside from that, there may also be swelling, okay, because of impaired return of blood. Okay, so what are the names of these diseases? So if it's arterial, one of the more common causes would be peripheral arterial disease or PAD, also known as peripheral arterial occlusive disease or PAOD. Contrast, if it's vascular or venous in origin, it's going to be deep vein thrombosis. Okay? So in deep vein thrombosis, there are blood clots in the deep veins of the legs. But sometimes, this could mobilize, becoming an embolus. And sometimes, the embolus is going to lodge. Of course, it's going to travel through your circulation. And it's going to lodge in the first narrow portion. So from the vena cava to the right atrium, to the right ventricle, then to the pulmonary circulation. Of course, it's going to lodge into the pulmonary vessels. So it's going to be called pulmonary embolism. Okay? So just to summarize, the diseases that you're going to consider are most likely going to be PAD or peripheral arterial disease or deep vein thrombosis. Okay? But of course, there are nuances. So let's start with the first concerning symptom, which is abdominal, flank, or back pain, because that is suggestive of abdominal aortic aneurysm. So this is a dilation of the abdominal aorta, and it's dangerous because it will cause sudden death, especially if it bursts suddenly. Okay, so if you have a problem with blood supply in your extremities, it's going to manifest as pain in the arms or legs. With arterial disease, there's a specific symptom called intermittent claudication. Okay, so this just means that when the patient walks or exercises, there is calf pain. No? Calf pain. It happens upon exertion and it gets relieved by rest. Okay? And the cause of that is the impaired blood supply to the muscles. Okay. Aside from exercise-induced pain, another manifestation of arterial disease is cold, numbness, pallor in the legs, as well as hair loss. Later, we're going to learn about the 6 P's of arterial disease. Okay? Swelling in the calves, legs, or feet is most likely venous. But it could also be what we call lymphedema, which is a problem with your lymph nodes, or lipedema, which is because of your excess fat, there's a swelling in your extremities. Okay. Second to the last, there may also be color change in the fingertips or toes in cold weather. So this is a specific vascular disease called Raynaud's phenomenon. So in Raynaud's phenomenon, upon exposure to the cold, the fingertips first blanches, so it appears white. Then it appears blue or cyanotic. And lastly, it appears rubor or red once vascular supply is reinstated. Okay, so white, blue, and red, Raynaud's phenomenon. Okay, and lastly, another manifestation of most probably venous disease, swelling with redness or tenderness. Okay, but all in all, you're just thinking it's either arterial or venous most of the time. Okay. Okay, but what's the pathophysiology of peripheral arterial disease? Actually, it's now different from any other atherosclerotic cardiovascular disease. So, for example, if you have a plaque that obscures blood flow, that obstructs blood flow in the coronary arteries, it's going to manifest as acute coronary syndrome or angina or myocardial infarction. If it happens in the cerebral arteries, it's going to manifest as an ischemic stroke. Okay? Ischemic stroke. But if the obstruction happens in the peripheries, then it's going to manifest as peripheral arterial disease. So the location of the symptoms is going to help localize the blood vessel involved or the artery involved. Okay. So you're going to ask for any fatigue, aching, numbness, or pain upon exertion. You're going to ask for any poor non-healing wound. Also, you're going to ask whether there's any pain present when at rest in the lower leg or foot and changes when standing or supine. Now, depending on the location, for example, if the symptom is mostly erectile dysfunction, then the artery involved is iliac pudendal. If the pain is mostly felt over the upper calf, the artery involved is most likely superficial femoral. Okay, so what if the arteries involved are the branches of the abdominal aorta? The manifestation there is abdominal pain after meals. So some of these patients manifest as having food fear or weight loss, usually after a cardiac event or an atherosclerotic cardiovascular disease event. Okay? So, the vessels involved there are either one of the three branches of the abdominal aorta. But most commonly it's going to be the superior mesenteric artery. That's why we have the SMA syndrome. Okay. Lastly, the abdominal aorta itself may be involved. And here we have abdominal aorta aneurysm. And your risk for abdominal aortic aneurysm increases if you have any first-degree relatives with this condition. So it's partly hereditary or genetic as well. Okay? So when you're investigating a potential arterial disease, you look for the 6 P's. Pain, paralysis, paresthesias is like pins and needle sensation. The pulse may also be weaker in that area. And it may be cold to the touch, called poikilothermia. Of course, there may be pallor in that area because of poor blood supply. Okay, all of these are caused by poor blood supply because of obstructed arteries. So now we're done with the things that you need to ask for in the history taking. Let's move on now to the physical examination. So for the physical examination, let's look at the step-by-step on how it's done. These are the key components. I have divided it between upper extremities, the abdomen, and the legs. So it still follows the general pattern, which is inspection, palpation, percussion, and auscultation. However, the percussion and auscultation steps are less important, especially in the upper and lower extremities. So for the arms, you do inspection as well as palpation. For the abdomen, you do palpation, inspection, and auscultation. For the legs, you inspect and palpate. And there are special techniques I'm going to teach you, specifically how to take the blood pressure, as well as how to palpate the aorta, as well as how to take the ankle brachial index. Okay, so let's start first with the physical examination of the upper extremities. So during inspection, we check for the size and symmetry. So if there is any swelling, the causes could be either venous in origin or lymphatic in origin. Okay, you could also look at the venous pattern. So if there's any obstruction, you could, like for example, upper extremity deep vein thrombosis. Because of that obstruction, the blood is going to try to find the way back to the heart. That's why sometimes the superficial vessels or the superficial veins could become visible or enlarged. That's what we call visible venous collaterals. Meaning there is collateralization. Nag-shortcut na yung blood trying to find its way back to the heart. Okay? Swelling and edema are also venous symptoms. You should also check the color and texture of the skin. Specifically in Raynaud syndrome, as I have mentioned, blanched, becoming blue or cyanotic, and becoming red. Okay? Lastly, you need to palpate and grade the pulses. So the normal grade is 2+. If it's bounding, it's 3+. If it's diminished, it's 1+. If you are unable to palpate it at all, it's going to be 0. So what are the pulses that you need to palpate? First is the radial pulse. Okay? So in some conditions, for example, aortic regurgitation, you're going to have bounding radial, carotid, and femoral pulses. Because there's reflux, right? So during diastole, the blood rushes back to the heart. So the pulse is going to be bounding. Aside from that, there's a condition called thromboangiitis obliterans, in which the radial pulse is lost entirely. Okay, so where do you palpate for the radial pulse? Radials, of course. You look at the side of the radius, which is on the side of the thumb, and you palpate using the pads of your index finger. You don't use your thumb because your thumb has its own pulse. So what's this figure in the lower half? This figure is of Raynaud's phenomenon. Okay. The next pulse that you're going to palpate, aside from the radial pulse, is the brachial pulse. So you palpate for the brachial pulse here in the brachial fossa. So take note of the proper positioning. You support the patient's arm here at the wrist, so that the wrist is slightly flexed and relaxed. Okay. So aside from the pulses, you also need to palpate for the epitrochlear nodes. Remember, the epitrochlear nodes drain the ulnar side of the forearm, as well as the little finger and the fourth digit. Okay? So, kailan ba nagiging palpable yung mga kulani dyan sa epitrochlear area? So, lymphadenopathy may be observed if you have any local or distal infection, or if you have lymphoma or even HIV. Take note again of the proper positioning. You support the patient's elbow, and aside from that, you use that supporting arm to palpate at the epitrochlear area. Okay, take note, remember that the epitrochlear area is located medially. Okay, so this is the medial epicondyle. Okay, so that's it for the peripheral vascular exam of the upper extremities. Let's move on now to the abdomen. So for the abdomen, you need to listen for bruits. So bruits are caused by turbulent blood flow. So what could cause turbulent blood flow in the arteries? So it could be an atherosclerotic plaque. Alternatively, it could be a narrowing or stenosis. So for example, if there is renal artery stenosis, it's going to cause a decrease in blood supply to the kidneys. And remember, the kidneys are important in regulating blood pressure. So you could have secondary hypertension because of renal artery stenosis. Okay, aside from that, you need to palpate for the abdominal aorta. you need to estimate the width with your two fingers. So, um, you're going to suspect an abdominal aortic aneurysm if there is a pulsatile mass with a width of 4 centimeters or larger. Okay? So, aside from the abdominal aorta, you also need to palpate for the superficial inguinal nodes. Remember, there are two groups, the horizontal group and the vertical group. The horizontal group drains the abdomen and the anogenital area, while the vertical group drains parts of the leg. Okay? If there are any lymphadenopathies there are many causes, of course, but if it's in the horizontal group, for example, it could be a genital infection. Okay? Aside from that, it could also be a lymphoma or AIDS. So remember this, in the horizontal group, it drains the abdomen as well as the anogenital area, but the vertical group drains the legs. For the physical examination of the lower extremities, you do inspection and palpation, just like the upper extremities. So you're going to inspect size and symmetry, and if there is any swelling in the thigh or cuff. If there is swelling, it could be either venous or lymphatic in origin. Okay? So, if there is cuff asymmetry greater than 3 centimeters, measured 10 centimeters below the tibial tuberosity. Okay? So, it's around the fullest part of the cuff. Then it doubles the risk for deep vein thrombosis. Okay? Remember, swelling is a venous symptom. Okay. Next, you look at the venous pattern. So, CS agents, for example, tend to have varicose veins. So, those who stand a lot or stay in one position for prolonged periods of time. Okay. The cause of that, of course, is the damage or the failed valves of the veins. Next, you look at the color and texture of the skin. Is it pale? Is it reddish, rubor, or erythema? Is it bluish or cyanotic? In some infections like cellulitis and thrombophlebitis, there may be warmth. Okay? So those with peripheral arterial disease may have pigmentation as well as non-healing wounds or ulcers of the feet. Just remember, blood supply is important for healing. Okay. Also, you need to note hair distribution. Are the legs hairless? Okay. And of course, the temperature. Is there perchlorothermia? Is it cold to the touch? Because atrophic, hairless, cool skin is seen in peripheral arterial disease. Okay, after inspection, you move on to palpation. What you palpate in the legs are also the pulses. Pulses may be lost in certain arterial conditions. So what are the pulses that you need to palpate? First is, so for the femoral pulse, you palpate for it midway between the anterior superior iliac spine or axis, which is located here, and the symphysis pubis. So you press midway here. What if your patient is obese and it's difficult to palpate the femoral pulse? Then you could use two hands like this, one on top of the other, just like in deep abdominal palpation. So after the femoral pulse, you move down to the knees. You palpate for the popliteal pulse in this position. Okay, so remember that the knees should be flexed. Okay. So alternatively, if you cannot find the popliteal pulse because it tends to be difficult to palpate, you could move to this other position here, in which the patient is lying face down, okay, or lying prone. But still, the knees should be flexed. Okay. Next pulse in the lower extremities is the dorsalis pedis pulse. So here, you palpate, actually, not around that area, but around here, in between the first and the second digit in this area here. Okay. Aside from the dorsalis pedis, there's another pulse in the feet, and that is the posterior tibial pulse. I would just like to emphasize that this is in the medial portion. So this is the medial malleolus. Okay? So don't palpate for it laterally. You're not going to feel anything there. Okay? Okay. So what if you're having some difficulty palpating the pulses? Well, of course, you need to position yourself properly, because awkward positions could decrease your sensitivity. Okay? Once your hand is positioned properly, you could probe around. You could linger and vary the pressure of your fingers. Okay? So, you shouldn't also think of the difficulty or the depth of the pulse. So, for example, if you're palpating for the popliteal artery, you may use more fingers than, of course, compared to the brachial or the radial artery. Aside from that, do not mistake your own pulse for the patient's pulse. If you need to confirm whether that's actually the patient's pulse, you could try to palpate the patient's carotid or radial pulse simultaneously. So, of course, it should be simultaneous. Okay? Before we move on to the special techniques, there are also ways to grade edema. Okay? So, there are many causes of edema. So, depending on the cause, it could be ascending edema in cardiac conditions. It could be descending, starting from the face, going down for kidney diseases or nephrologic conditions. Okay? So, it depends. But either way, you're going to rate it depending on these factors. You're going to press on it, and you're going to check whether it rebounds. So, if there's any barely detectable impression when the finger is pressed into the skin, then it's 1+. If there's a slight indentation taking around 15 seconds to rebound, it's 2+. If it's deeper and takes longer to rebound, around 30, it's 3+. And if it takes more than 30 seconds, it's going to be 4+. Now let's move on to the special techniques. So these are the special techniques that you need to learn. So these also have relevance in cardiology, of course. Okay. So what you need to learn first is the ankle brachial index. So here's the formula. It's just a proportion of blood pressures. Okay. But take note that the right ABI corresponds to the right foot. But the denominator is the highest pressure in both arms, meaning you could measure the right ABI from the right foot divided by the left arm. Okay? So in other words, you take the highest pressure in both arms. Okay, so that's the right ABI. The left ABI has a similar formula. You just take the highest pressure in the left foot and divide it by the highest pressure in both arms. Okay, so values more than 1.4, meaning increased ankle brachial index, suggests that it is a non-compressible calcified vessel. So you see that mostly among the elderly. However, what's more worrisome is an ankle brachial index of a value less than 0.9, meaning the blood pressure in the arms are much higher compared to the blood pressure in the feet. That's because it's suggestive of peripheral arterial disease. So it's possible that there is an atherosclerotic plaque blocking the way, blocking the arteries going to that foot. Okay? Oh, by the way, where do you measure these blood pressures? So for the arms, you measure it using the brachial artery. But for the feet, you take it either from the dorsalis pedis or the other artery. Okay, so here's the interpretation. It could be mild, moderate, or severe, depending on the value of the ankle brachial index. The normal value should be more than 0.9, meaning the blood pressure between the feet and the arms should be just around equal. So this is the last special maneuver I'm going to teach you, and this is the Allen test. So when do you do this? You do this if you want to check the patency of the radial and ulnar artery, meaning if there's any collateralization, if just in case that the radial artery gets clogged or clotted. Okay, so you do this before doing an arterial blood gas extraction. So in an arterial blood gas extraction, you get blood not from the vein but from the artery, specifically the radial artery. Now that's dangerous because artery provides blood supply, right? So, if the ulnar artery is clogged as well, then that's going to cause ischemia of the hand if the radial artery gets punctured. So, how do you do the Allen test? You place the patient's hands on their lap. You ask them to make a fist. Okay? Then you apply pressure here on the radial and the ulnar artery. You ask the patient to open, and then you release the pressure over the ulnar artery. So normally, if there's patent blood supply in the ulnar artery, then pallor is not going to last a long time. So pallor should be less than 5 seconds. Allen test is going to be positive if there is persisting pallor greater than 5 seconds. It suggests occlusion of the ulnar artery or its distal branches. Now there is a variation of the Allen test which uses a pulse oximeter and is called the Barbeau test. Okay? So how do you record your findings? So you could write it like this. Extremities are warm and without edema. No varicosities or stasis changes, meaning you checked for any venous symptoms. The calves are supple and non-tender. No femoral or abdominal bruise. No, the brachial, radial, femoral, popliteal, dorsalis, pedis, posterior tibial pulses are 2+ and symmetric. Of course, if it's abnormal, you could tabulate the pulses like this. You could also note that the extremities are pale below the mid-calf with notable hair loss. So what does that suggest? It suggests an arterial disease. Okay? Okay, so that's it. You just put all your findings there. So, we're near now to the end of our lecture. Let's discuss health promotion. Okay, health promotion. So, for health promotion, we screen for 2 conditions. Lower extremity pad or peripheral artery disease, as well as abdominal aortic aneurysm. Let's start first with screening for lower extremity pad. Okay? So, peripheral arterial disease is a marker for cardiovascular morbidity and mortality. It's a harbinger for functional decline. If you have peripheral artery disease, you are at 3 times risk of death from myocardial infarction as well as stroke. Because, as I have mentioned, these are all part of the same pathophysiology, which is atherosclerotic cardiovascular disease. So, how do you screen for peripheral artery disease? You use your ankle brachial index. Okay? So, how do you do it? As I have mentioned earlier, you just take the blood pressure from the brachial artery, the dorsalis pedis, and the posterior tibial artery. Okay? And remember the formula I have shown you earlier. And the interpretation depending on the value, either mild, moderate, or severe arterial disease. Okay, I'm not going to repeat it because I have mentioned it earlier. Now let's move on to screening for abdominal aortic aneurysm. Next is screening of abdominal aortic aneurysm. But first, why do we need to screen for AAA? It's because the dreaded consequence is rupture. When this aneurysm ruptures, it's most likely going to be fatal. Most patients die before reaching the hospital. So the chances of rupture and mortality increases dramatically when the aortic diameter exceeds 5.5 centimeters. So there are certain risk factors associated with AAA, and these are older age, male sex, smoking, as well as family history. So you need to ask for that during the history-taking portion. So what are some other potential risk factors? History of other vascular aneurysms, a taller height, coronary artery disease, cerebrovascular disease, atherosclerosis, hypertension, and hyperlipidemia. So what's the recommended screening method? The recommended screening method is abdominal ultrasound. Palpation is not likely to be sensitive enough, so it's not actually recommended. But of course, you should know how to do it, theoretically at least. Okay? So the sensitivity of an abdominal ultrasound is 94 to 100% with a specificity of 98 to 100%. When do you do screening for AAA? You do it one time for men aged 65 to 75 who have smoked more than 100 cigarettes in their lifetime. Okay? So you do it for this because they have the risk factors: men, older age, smoking. Okay? And that's just it for our lecture on physical examination of the peripheral vascular system. If you have any questions, just message me. Thank you, everyone.